Hello, thank you so much for joining us. I will briefly review how we can stimulate recovery and brain plasticity in neurorehab and illustrate what to me is the biggest current challenge, that is translating this huge amount of scientific brilliant studies into clinical reality. We try to do that together with the team, the Giga Consciousness and Coma Science Group at the University Hospital in Liège, but also our team in Canada at the Cerveau Brain Research Center and in China at Hangzhou Normal University. So for the past 25 years, we've really, as many others now, been combining modalities from different neuroimaging techniques, historically being positron emission tomography, high-density EEG, structural and functional MRI. And truly now we see that can and should more impact how patients can increase their neurological function after severe traumatic brain injury, but also hemorrhage, also anoxic, hypoxic injury. We do that together with a number of partners, such as what you see here, Trainem Rehab in Antwerp, Belgium, and Klinik in Schmiedich in Germany. So it's a great pleasure to present the work of the team, brilliant minds such as Olivia Gossery, Aurore Thibault, and all others of the Coma Science Group, who have been for such a long time now documenting synaptic activity using FDG, metabolic PET imaging. You see here the cover of Annals of Neurology a couple of years ago, and you see on the image how there is a massive global decrease in metabolic activity in unresponsive wakefulness, people awakening from coma but showing only reflex behavior, which is very challenging to identify. And many of them are in a minimally conscious state, and that is typically characterized by higher metabolic activity, especially in the frontoparietal internal and external awareness networks. And then you see these technologies, both with PET but also with high-density EEG connectivity maps that you can see on the cover of the journal, identify what we call MCS star. It's the dissociation between residual cognitive activity but disconnected from motor outputs. So these are patients where it's only the imaging technologies that permit us to show that there is still a working mind, working brain. We also look at differences, of course, in structural MRI. You see the result of the voxel-based morphometry. So these are very, very exciting times. This is a recent review of 135 patients sent to our expert center from all over Europe. And especially important for today's lecture is that this is now translating to new therapeutic possibilities. And I think for a very long time, we had maybe a sort of therapeutic nihilism. We thought, well, there's nothing we can do for none of these patients who survive coma but can't communicate. And that was very probably not true. We were so afraid of giving people false hope that we had created this false despair. And neuroimaging and the identification of the awareness networks that you see in red, external awareness, in blue, internal awareness, and the dynamics with thalamic nuclei, but also with basal ganglia in the so-called frontoparietal mesocircuit hypothesis, we can now stimulate part of these networks. And that can be done pharmacologically with zolpidem, very paradoxical that a sleeping pill can awaken people, with amantadine working on dopamine and NMDA receptors, but also with deep brain stimulation of the thalamus and the pioneering work of Nicholas Schiff, now followed by many others. And then there's possibilities using, of course, non-invasive stimulation, and a big pioneer is Aurore Thibault with tDCS, transcranial direct current stimulation, and all the other possibilities now through vagus nerve or vestibular stimulation. So that is wonderful, and also applies actually not just to severe but also moderate, mild brain injury. And we look together with our partners in Canada to how neuroimaging can help us to deal with the challenge of post-concussion syndrome. We, and I think this is important, are now also applying this not just to the field of neuroplasticity in pathological conditions, but also very challenging ones such as the astronauts. And there's up there now 7 people in the International Space Station. So we use that model of zero gravity and how the human brain can adapt to very extreme conditions, again, thanks to neuroimaging. We also study top athletes. Recent paper in the world champion Guillaume Néry, who is diving on one breath, 139 meters, where when we study his brain using, as you can see, high-density EEG and fMRI, and he's in a very peculiar state of mind. He is in an altered state of consciousness, really dissociated, absorbed, quite similar to what we saw, by the way, in the Buddhist monks we've been studying. And so that knowledge and also the technologies that permit to monitor that, you can see it here, studied together with Israel, where we use the NeuroSteer simplified way to monitor the electrical activity of the brain and mind, helps us to increase performance. So working with these very exceptional brains, you see here Mathieu Ricard, the translator of the Dalai Lama. We had many other expert meditators for those interested. There's a no-nonsense meditation book, but this is, I believe, very exciting that we now have portable ways to capture and to do brain mapping that gives people feedback and can help actually both in disease and health to, what I would say, empower us and employ more the power of the mind. We also work with a number of industrial partners, as said, and one very exciting collaboration, given we have a long tradition of using medical hypnosis in the hospital, where people undergo surgery while being awake yet, again, absorbed and dissociated, is the possibility of immersive virtual reality. So we have a number of projects and papers showing, again, that we can use neuroimaging and then especially, of course, EEG to, again, optimize these techniques and help clinicians increase patients' comfort. We have a long tradition, actually, in Liège to use neuroimaging to capture the effect of neuromodulation, both invasively. You see here an example of an old paper with occipital nerve stimulation in headache, and then the non-invasive possibility with tools like Cephaly, initially a Belgian company, now an American one, and you see with PET, because these are devices that are not MR compatible, we can see changes and decreases in part of the pain matrix. So this is very exciting, and neuroimaging is both helping us to understand neuroplasticity, and as we will see, it is also helping us to identify the best candidates for these interventions. Another paper is here a collaboration where we look at patients with stroke. These are chronic patients. You see the time after their injury. They have a drop foot, and so we implanted a peroneal nerve electrical stimulator to improve their gait. This is really top tech, and we see both in FDG, PET, metabolic imaging, and voxel-based morphometry and T1 high-resolution MR and functional MRI, that these interventions, years sometimes after the stroke, still can modify and improve neuroplasticity and, of course, motor possibility and quality of life in patients. So this is terribly exciting, and we see more and more how truly we go from bench to bedside. Another example, again, this is Trainham Rehab Center, a patient I follow now for many years. He came to our lab with the label vegetative state. In reality, we quickly found out he was conscious, minimally conscious, couldn't communicate, and actually is a very rare atypical post-traumatic locked-in syndrome patient. So we should be very careful not to judge a book on its cover. The added value of neuroimaging is increasingly clear, and also the impact of the neurorehab that becomes, again, high-tech. You see the robots, exoskeletons that can permit these people completely or nearly completely paralyzed to walk again. It doesn't only stimulate the motor system, but also, of course, cognitively impacts the quality of life, and yet it needs also caring, compassionate therapists. So that's, to me, the challenge, to really make medicine that becomes hyper-specialized, hyper-technological, and yet we need to keep the human connection, and that's what we try to do together with our international partners. So in a nutshell, what you see, there's 3 cases here. Again, these are chronic patients. You see the hypometabolic regions, and then in red, the increases that we observe using voxel-based SPM analysis. So the old dogma that when we don't see any recovery after 6 months, 12 months, then we will never see any improvement, that is wrong. We now can and should improve the trajectory of care. You, of course, also know the numerous developments in brain-computer interfaces we've been developing with Adrian Owen and others, how one can use motor imagery, for example, captured by fMRI to give them a voice. The challenge, again, is to translate that to clinical reality. It's wonderful to be able to do that with, again, partners such as GTEC, the only commercially available BCI, the Mind Beagle, you see we use here in the University Hospital Intensive Care Unit, a patient, severe post-traumatic brain injury, and you see how we capture the EEG, and we can, first of all, show that some of these patients understand simple commands, and next can use that to establish a functional communication. So that's current work in progress to, again, use neuroimaging and better characterize why do we have these extraordinary patients where we think they're completely unconscious, and yet through fMRI, PET, EEG, we can see that there's more happening in their brain. So we ask them questions like move your foot, move your hand. We don't look at the foot or the hand, but we see that their brain is activating. And then with other, and this is the added value of multimodality here, we use PET to identify those patients where there is covered command following. You see it on the image below. There's way more metabolic cortical activity in those rare but existing patients that can show us that they're still inside. And then, of course, we can stimulate the capacity of the brain to recover from these very severe injuries. And I think a very promising tool that is, a lot of research in the field of tDCS, and I really should emphasize the pioneering role of Aurore Thibault, using 2 milliampere, 20-minute non-invasive stimulation. You see here a theoretical model of electrical fields. It should be emphasized, we do not yet understand the exact mechanisms of action, but we do see in a number of sham control studies that there is an effect, and then combined with the robotic therapy, we currently show that really we can offer something for these patients. So that is wonderful. We go to personalized neurorehab based also on neuroimaging, and we see the effect. We can predict also the patients that are going to improve after invasive, non-invasive brain stimulation. That's what you see here. Just you see the activity. You see the difference in coma recovery scale. So those who did improve, and they showed also higher activity in prefrontal but also thalamic structures, both with functional and structural imaging. So that's the good news today. We are actually moving from high impact papers and some small cohorts benefiting from this to really translating it to clinical reality in our hospitals, both in Europe, in Northern America, and our partners also in China. And there's numerous ways to do that. We mentioned amantadine. You see the regions that we showed that activate with that drug. Zolpidem, very, very challenging, and I think we need to increase our research efforts there. But also then, of course, stimulation. We mentioned tDCS. You can here see RTMS, ultrasound, and the work of Martin Monti. So vagal nerve stimulation. It's very exciting to see how really your research is impacting clinical care. So there's a review, and I invite you to continue this line. I'm personally involved as 5 children, and my son, you see here, at cerebral palsy, and as you can see now, you can barely notice how that quite severe brain injury through fun neuro rehab has changed not only his neuroimaging findings, but of course also his motor capacities. I thank you very much, and of course I need to thank the incredible team and our partners all over Europe and in North America. For those who are interested, there's a couple of popular books, some of them translated in English. And also I want to mention that I created Mindcare Foundation, which is exactly about translating this to the clinical reality and answering patients and their families' needs. Thank you very much, and happy to stay in touch and move the field forward. Cheers.